I think there is no need to introduce Leona Gilbert. She's our host today. For the rare person who don't know her, she's a specialist of cell and molecular biology. She has a doctorate in biotechnology. She's CEO of a small company, and she's developing innovative diagnostic platforms. So thank you for the organization of this meeting. And please.
So I am going to find my space and speak slowly because I know that I've been speaking rush the whole weekend. So thank you for sharing this time with me. My title of my talk is The Infective Mosaic, Mapping Complex Immune Responses in Tick-borne Disease Patients. These are my disclosure statements that were already mentioned. And this is my aim. My aim is to try to have us understand and answer this question. What if chronic Lyme disease isn't only about the pathogen, but also about the pathogen wreaking havoc on the immune system? And you're going to tell me, well, that's obvious. These individuals have issues with their immune system, but correlation doesn't mean causation. And very rarely do we have a mechanism. So my aim is to provide a roadmap to chronicity, a mechanism that eventually leads these patients, chronic Lyme disease patients, to autoimmunity. Because the motivation of this story, is your story, our story. This is Jonas Berghall, a Finnish well-known film director, writer, and I said director already, but he has won awards on his documentaries. He spent 12 years to get a diagnosis, seen 82 doctors, spent 60,000 euros, got tested with Tick-borne. His doctor, Richard Horowitz, developed a personalized treatment protocol, and he is 95% recovered. He really says that Tick-borne saved his life, but it's not just about Tick-borne. It's about actually thinking that the Lyme legacy isn't just microbial. There's something else going on, and that's the immune system. So let's put a mechanism there and understand this. Because I've been hearing constantly, the problem is that we don't have good diagnostics. But if you look at the whole impact of this tick-borne disease problem, and specifically Lyme disease, we actually forecasted years back by 2050, 2.4 billion people have seen or will have a tick-borne disease. And actually it was published in 2022, 1.2 billion people already have serology or have seen Borrelia. And if you use those statistics, like you said, up to 30% of the people develop chronic Lyme disease, well, that means 20 million people. So we need to do something about this. Somebody knows somebody that is actually a chronic Lyme disease patient, and the most recent one was Justin Timberlake. So I keep hearing this narrative. Why standard tests fail? Actually, we do have good tests, and I'm going to give you the evidence. We just need to employ them, okay? The statistics with Perry and Cook was years back, not based on updated information. They said it's 60% sensitivity, but there's better tests like Tick-borne. And this Tick-borne test is not the only test that have these sensitivities. We need to go and look at your immunes testing as well. And I can tell you why, because they have a platform of different pathogens, okay, especially 3 different species of Borrelia. That has totally increased, okay, the sensitivity from 60 to 95 and 98 specificity. So Tick-borne is the method that we're using to screen and categorize patients within this study that I'm going to show you, okay? It is a diagnostic that actually an indirect immune response against 15 different pathogens. We test for IgG and IgM antibodies against these 15 different pathogens. It's quantitative and it's qualitative. And it's one test, not different panels. okay? And because that can be very expensive. So it's really affordable for healthcare systems and for the patients. And this is one of the clinical studies, okay, that validated this test. One of them. This is 432 characterized seras that were characterized on other platforms and then used on Tick-plex. So we had CDC acute, late sera panels, CDC negative, post-treatment Lyme disease panels, immunocompromised, meaning CD57 was low. We had healthy controls, okay? We tested them for IgM and then IgG, okay? But this is why we're here today, because I want to demonstrate and give you a mechanism of this chronicity roadmap. And it really starts with, for us, in our hypothesis that the persistent form is there. What does that mean? We know that persistent forms exist. We know that they can come out of their round body shape, go back to its parent form. So let's give a mechanism to this now. So really, we have good diagnostics. We need to start thinking and changing the paradigm and actually demand as clinicians and patients a multiplex testing, okay? And simultaneously test for IgM and IgG for multiple pathogens, but not panels after panels after panels after panels. We have to be more clever than that. So for faster diagnosis, faster treatment, more cost-effective and clinically relevant panels, we should be using Tick-plexing, multiplexing. So, but because this handles the microbial information, but as my aim is to demonstrate to you that we should be going into understanding what else is going on in the body. So out of the data, I want to bring some light and clarity to try to develop this roadmap to the different stages that leads to autoimmunity. So it starts with actually looking at these patients and seeing really, is there a significant correlation between persistent forms and chronic Lyme disease? Are persistent forms valuable in diagnostic clinically or not? So of course, we have lovely Jackson Gordana's data here, and we can characterize the serology of these patients if they have antibodies against the spirochete alone of Borrelia or the persistent form, or do they have antibodies against those two forms? And just where the stars are demonstrates there's a very significant immune response against the persistent form. So the leading tests right now, when they don't have this, we're missing out on these patients. And also, of course, we have our own data set from Finland, and there's a chronic data set coming from Australia. Only on this slide, but we have lots and lots of data. But when you look at the data here, wow, what do you see here? On the left side is IgM responses. Again, we use Tick-plex, so against those antigens, okay, on the rows and columns are each of the patients. You can really see this, right? No, you can't. I want you to just get the feeling of this. These are characterized acute patients by other tests. We took their serology, we used it on Tick-plex, and we put them, each patient's in a row. Boo, 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 boo. We also got disseminated patients as well. Okay, as you can see here, put them in the row. IgM response is on the left and IgG response is on the right. Tick-plex results will give you yes, green meaning negative, yellow meaning borderline, but red meaning positive. Okay, and the feeling that you get when you're looking at these colors is that in acute, there's a lot of negative people, which there should be, because they need time to develop their antibodies, but we start seeing some red. And that's interesting, the red. So they're positive for these antigens and they're acutely infected. Then look at the dissemination pattern. You see more red coming, which means the person is developing antibodies against a lot more of the antigens. And then I go to the next slide. Look at the chronic patients here. Both panels here are characteristics of chronic Lyme disease patients that were, by the way, tested previously with other tests and then used on our test. And what would the clinicians say? They would say, oh, that's false positive, or that's overreacting. But actually, let's dive into it, because these are biomarkers now. So the percentage of the general population of tick-flex on patients right now is that we're seeing 3% of this population having a universal positive response, meaning positive against the board for IgM. 1.5% of IgG, people that have an IgG response, 1.5% of them are universal positives across the board against those antigens. And then if you put the two antibodies together, we're seeing 1.2% of the people having a universal positive response. Incidentally, if you characterize these seras a little bit more and look deeper into them, if you put that universal positives on any serology test at all, Eurimmunes, IgGenics, whatever, it's going to be positive. So what's going on? What's going on? Why are they positive? So we took patients that were characterized with autoimmune disease, and look at them. They're really positive. So as we see more and more positive patients, universal positive patients, meaning they have an antibody response against everything, we started developing some hypotheses. All right. So we thought, okay, we saw autoimmune patients being brightly red, so there must be something going on with their immune system. Well, you know that chronic infection impairs immune function. It stimulates cytokine storms. It promotes T cell exhaustion, B cell exhaustion. They get exhausted because they're trying to do its job, but doing your job over and over and over again, we're going to be exhausted. We're going to be exhausted tomorrow. So we also know that war and trauma and stress exacerbates this immune suppression. We know this. And we also know then, in the end, it's very difficult to interpret test results, especially when people have an immune dysfunction or dysregulation in their system. Especially if they're saying that there's negative control or negative results on everything, but they're sick. There has to be something else there. So, full disclosure, I was reviewing a paper, I got some ideas from that review and said, let's go and test these samples, universal positive samples with controls against 3 biomarkers. Biomarker number 1 and 2 correlates and have demonstrated through publications that they are biomarkers for autoimmune diseases. Biomarker 3, okay, regulates the immune system. So what we've done is we are going to detect directly the biomarker 1, 2, and 3 from the sera of these patients. Okay, from these non-universal positive patients, and then universal positive patients. So biomarker 1, if you group them non-universal positives, okay, remember they are the people that don't have antibodies against everything, but universal positives does have an antibody against everything in serology. If you go and take their sera and look for biomarker 1 and bar chart it out, you can see that universal responders, universal positive people exhibit moderately higher biomarker 1 levels. Okay, though not statistically significant, but it does hint at stronger immune activation trends. And if you take those non-universal positives and universals and break it down to actually negative, not having any antibodies of IgM and IgG, or non-universal positive negative IgG antibodies, or negative IgM antibodies, or now universal positive IgG individuals, universal positive IgM individuals, and then we have, remember, the 1.2% of the people that have a response to IgG and IgM together. okay? If you look at them for biomarker 1, universal positive G patients have significantly elevated biomarker number 1. And this suggests a strong IgG-driven immune response, while the other groups are basically close to the controls. So biomarker 1, remember, is a marker for autoimmunity. So again, biomarker 2 now, again, another biomarker in the blood that correlates, causes autoimmunity. All right, so again, we took the non-universal patients and then the universal positive SARAs, and we grouped them. And you can see globally that the universal responders had nearly double the biomarker 2 amounts, okay, suggesting a more intense or broader immune activity. And it's those shy, this is words of dear colleagues, statistical significance. But let's break them down again. So negative antibodies, people, okay, of any of the IgM or IgGs in green, non-universal positive for IgG, non-universal positive for IgM. Now the universal positive for IgG is in orange. Universal positive for IgM is yellow. And then universal positive, again, that group of people that have antibodies for IgM and IgG is in black. So you can see what can forecast what I'm going to say. Universal IgM respondents stood out with significantly higher biomarker number 2 amounts, indicating a strong IgM-driven immune activity. So the last biomarker, again, non-universal positive responders, universal positive responders in red on the right. So universal responders showed slightly higher biomarker 3 expression or levels, okay? And the difference wasn't really that statistically significant, so it's suggesting minimal diagnostic or clinical relevance. Because remember, we can't always have what our hypothesis want. It's good that we see that this marker for this case is not so good yet. But if you look closer into separating these people, okay, remember originally universal positives having antibodies against everything, okay? We break it down to negative IgM and IgG, negative IgG, negative IgM, universal positive IgG in orange here, universal positive IgM in yellow, and then of course our last group where they have antibodies against everything with IgM and IgG. So universal positive IgM patients, again in yellow here, exhibit significantly higher biomarker number 3. And it's interesting because this really implies that there's a strong IgM responses that may drive this expression and dual responses that may suppress it, because it's, again, not significantly relevant up here, but is definitely significant in the bottom. So we have IgG, IgM, if they're together, it's another biomarker, and we have these new 3 biomarkers that correlate to autoimmunity. So what? This is a correlation. Okay, let's try to develop another hypothesis and that roadmap to explain and give a mechanism to immune dysfunction. And this is what I am trying to provide here right now. So the tick-borne disease patient roadmap to immune dysregulation, dysfunction, however you want to call it, is in 3 steps. And this is explaining the chronicity of these patients, within these patients, and how they are developing, in the end, autoimmune diseases. So the first stage, early chronic phase, the immune activation onset. The immune profile is a persistent IgM response, universal positive IgM. The findings to support this stage is the universal IgM antibodies, as I said. It is significantly elevated in biomarkers 1 and 2, and biomarker 3 levels were also increased, but well, and it does indicate endothelial activation. The second stage, intermediate phase, which has a mixed humoral response. The immune profile is IgM and IgG dual response, universal positives, remember 1.2% of the patients. And our findings is that these universal positive IgG patient subgroups showed significantly elevated levels of biomarker 1, but biomarker 3 was reduced in these dual responders. So we can pair these up and see and take these ratios and see what stage these patients are in. And the third stage is a late chronic phase, so leading to systemic inflammation and autoimmune predisposition. And again, this is the expansion of the polyclonal and autoreactive IgG production because we see the universal positive IgG. And the findings is that universal positives have nearly doubled the amount of biomarker 1, single versus non-responders. It's really suggesting systemic B-cell activation. And minimal but not significant rise in the biomarker number 3. So this leads then to context, and the context is this roadmap. So for interpretation with using these 6 biomarkers, okay, the first stage, the interpretation that you see these biomarkers, you see isolated IgMs that is positive or universal positive that's going on, hyperactive B cell activation and endothelial stress is occurring. That's the interpretation. You can then treat on this. You can have an intervention. Number 2 stage, intermediate phase, the mixed humoral response. The interpretation is that there is a persistent humoral activation, potentially balancing by IgM modulated immune signaling. It's trying to counteract itself, but then there's a threshold, and that is stage number 3. The late stage phase, systemic inflammation and autoimmune predisposition. So in the interpretation really is that the biomarker number 1 may act as an early indicator of autoimmune conversion. So we go from acute dissemination to late to chronic, but there's 3 stages in the chronicity of chronic Lyme disease that will lead to autoimmunity. And so with these mechanisms, we need to not only look at the microbial profile, but we have to look at the immune system. And these biomarkers are very standard. It's really interesting that they can be employed quite quickly. So it's not just about the microbe. It's also what the microbe did or is doing to the immune system. You're going to say, yes, I know this. Well, now we have mechanisms. We're going to dive deeper into stopping these. So the impact for patients is this. So hopefully they'll have a validated and faster, hopeful path to treatment because you really can stop at these places, okay, on these stages and not just group, post-treatment Lyme disease syndrome because they have autoimmune diseases too. There's a correlation to this. Everybody's saying, yes, that's a no-brainer. But now we can really break it down and hopefully prevent some of these things. And for scientists, this is really a new paradigm of the immune-driven chronic diseases. We need to look at really these checkpoints in the biomarkers. And for healthcare providers, I hope I can provide you practical tools soon, but the paradigm is using multiplexing testing. Okay, if it's not Tickplex, then something else, but you're not panels after panels after panels. Let's be clever in the testing. Okay, and hopefully that will shift the clinical care. I will really want to thank, partner in crime here, Gordana and Jack, okay, for your continuous support. Many others, because we just got monkey data to really support what I've just said here. I haven't processed it completely or had the time this weekend to put the slides in. Very sorry for that. And so there are many others that are associated with this. And actually it's the patients. We need them. We need to be united. And I hope this conference provided that too. I have last 2 slides here. Before I give the floor quickly to Sigrid and then back to Gordana and so forth. Frontiers in Cellular Infection Microbiology has sponsored this conference as well as our other sponsors in the back. And we have a special issue that we're driving the proceedings of this conference into this journal, and we want to empower everyone to employ us, and we could help you get published in this journal. They also sponsored the 2 posters, woohoo! And Teo is here, a co-topic editor, and Cannell's wife is the other one, which is great. So this is open now, and this special journal will go on for the next year. I want to say thank you very much for your attention, for being on time. I'm even early, yay, because we have some housekeeping things for you. So thank you so much for being present.
Incredible work. Thank you so much. Were you able to quantify your data, pre or post-COVID SARS-2 spike protein load?
Not yet on these samples, not yet, but you know we can because we have the test. But it's a good point. But these samples that you actually, all these samples were pre-COVID. All of these are.
But in our clinical correlation, patients were sicker in our cohort, had much higher IgM and IgG, IgA titers in the SARS plex.
Yes, but your post or pre? Where are you pre? Oh no, was it post?
It was post 2022 and 4.
Yeah, exactly. Yeah.
I may have missed this, but curious minds want to know, what are the 3 by?
Yeah. I know. You'll be surprised when I disclose that. You will be surprised. You're gonna go, come on. So we are really trying to get this out fast. So fast, but robustly and scientifically, and making sense of all of this so that we can empower the healthcare providers with these tools. Okay. And I say fast being, you know, the IVDR regulation in Europe takes a little time. But this is definitely something that we want to get out there soon. Yeah.
What it is supposed to correlate it with total IgG and IgM as well.
Yeah.
That for patients as well as a matter of course.
Well, I mean, yes, it could be. It could be. I'm just thinking that I'd rather have subtyping of the isotypes on these and then totals. And that could definitely, obviously it's not those biomarkers now, but yeah, I would love to do that. That it could lead to some other information. Yeah.
Thank you for that. Lovely talk. I'm so for the autoimmune, like parrots and all red, it was all red.
Yeah.
Like did those Sarah have defined autoimmune conditions, or were
Yes.
looking for a certain marker?
No, they were an autoimmune panel that was diagnosed actually with lupus. But
So did they all have them? Or-
Yeah. yeah, Stan, Legacy, Sarah's. This is from Guy's work.